I'm thrilled to have for the third time my colleague and friend, Mr. Bassel Duwaji, who is an application specialist and a guru in functional disorders and at least reading the manometries and the pH monitors and things that we usually do in order to diagnose our patients. So, Bassel, thank you so much for joining us for the third time. Very happy to have you.
Hi, Doctor. Good evening. Thank you for this series of webinars. I think it will be very useful in discussions for both of us and also for all the attendees.
So last two webinars we spoke about what a normal manometry would look like, and then we spoke about also the setup of the room and of the device and all the parameters that we should know in order to actually perform a manometry successfully. And today, I think it would be really beneficial to dive into how to read manometry that is actually pathological, when things are not okay, when it's not looking normal, and we should diagnose those conditions and why it's important to distinguish them. So we're going to be focusing mostly on achalasia today, but we will also be mentioning some of the other esophageal conditions. Does that sound good to you?
Yes, okay, yes.
I thought that before I hand over the word to you, where you had prepared a very nice presentation here for us to go through some things to show some examples. I thought that would be really beneficial for the audience to have an overview of the conditions that we're going to be speaking about today. So before we dive into high resolution manometry and some of the tricky tracings, I want to zoom out for a few minutes and frame where achalasia actually sits in the spectrum of esophageal disorders. So most of what we see in clinics is not rare motility disease. It's very common problems. What we see reflux, we see functional symptoms, we see usually structural complications of reflux. And globally, GERD, the gastroesophageal reflux disease, affects almost 1 out of 7. So this translates to more than 1 billion people worldwide, and this is what we see in the clinic. And the second growing group are inflammatory disorders, such as eosinophilic esophagitis, quite underdiagnosed for a long time. And we know that this can be from 100 to 150 people per 100,000 in prevalence. So about 1 to 700 people in some Western populations. And we think that actually there is more people that have that, but they just go undiagnosed for a very long time, or they never actually get the diagnosis. On top of that, we have structural malignant disease, septic strictures, Katsky rings, post-surgical anastomotic problems, and of course, esophageal cancer, all of which can present with dysphagia, which is the most important symptom that we're looking at today. And there's only a small fraction of our dysphagia patients end up having a primary motility disorder. So achalasia really is a rare disease, and with global pool data, they suggest that there is an incidence of about 1 to 1.5 people per 100,000 per year, and prevalence of about 10 to 11 per 100,000. So it's quite rare. So from base rate perspective, when someone walks in with dysphagia, statistically speaking, they're much more likely to have reflux-related disease or eosinophilic esophagitis or structural lesion rather than true achalasia. But the impact of missing achalasia is high, and it's a disabling condition. And once recognized early and subtyped correctly, we can actually offer very effective therapy in many cases. So if we think symptom based, most esophageal patients present with like combination of sort of heartburn, regurgitation. They may be having dysphagia or food sticking in the esophagus. They may describe. They may describe some non-cardiac chest pain. Some would have weight loss, recurrent cough, or even aspiration pneumonias. Then where in classic reflux disease, heartburn and regurgitation dominate, often meal and posture related with at least partial response to PPIs. And eosinophilic esophagitis, dysphagia, and food impaction are prominent, usually in younger people. Endoscopy would usually show something that we can actually discuss and give the patient diagnosis sometimes even before we get the histopathology results. Malignancy tends to give relatively short history, rapidly progressive dysphagia, often starting with solids and then involving liquids and early weight loss, and sometimes features like iron deficiency anemia. The achalasia sits in a different corner of this map, so it is important. The typical achalasia story is that it's insidious, but slowly progressive. Dysphagia that from early on involve both solids and liquids. Patients really, if you really push them to tell you what it feels like, regurgitation of undigested food or saliva, particularly after meals or when they're lying down. They may complain of retrosternal chest pain or discomfort. They have lots of spasm going on. They lose weight over time. They may have heartburn-like symptoms that do not respond to PPI. So I can count a number of times I've seen patients like this that are on PPI for many, many years. And they will have sometimes nocturnal cough or aspiration. So it's from overflow or stasis. So that profile where you have like that kind of progressive dysphagia of solids and liquids with regurgitation symptoms should already put achalasia on the differential diagnosis list before we even touch the manometric catheter. So if we were like now to achalasia is a primary motility disorder compared to everything else almost that is secondary, and it's characterized by two manometric features. That I'm sure you're going to be speaking more about. But the most important thing is there's impaired relaxation of the lower esophageal sphincter, and there's absent peristalsis in the esophageal body. And pathologically speaking, or pathophysiologically speaking, this is driven by degeneration of some of the inhibitory neurons in the myoteric plexus. So the result, there's a functional obstruction of the esophageal-gastric junction. And the esophagus is trying to push the bolus down, but the junction does not relax properly. And over time, the body loses organized peristalsis, which leads to dilation. Food that starts like filling up, that leads to the complications that we mentioned. In the worst case scenario, we see something that we call sigmoid esophagus in advanced stages. And in order to diagnose that, we have touched upon that earlier. So GI endoscopy to exclude structural disease or malignancy, pseudoachalasia, sometimes it's called, and to look for retained food, stasis, height resistance at the cardia, and you got to be careful in distinguishing a hernia from some tightness, because sometimes having a big hernia causes some sort of tightness. We need to do a barium swallow, ideally a timed barium swallow, looking for the classic bird's beak tapering and late emptying, and high resolution manometry, which is the gold standard. And nowadays we have even the endoflip that is being used regularly. So what makes achalasia even more, I think, difficult and confusing for a lot of people is that you have this elevated integrated relaxation pressure as a junction and absent peristalsis, but then you got to subtype it. And then we have the 3 subtypes: type 1, type 2, and type 3. And type 1, that's when you have 100% failed peristalsis and minimal pressurization. Always need to keep in mind they all have elevated IRP. Then you have type 2, which has an esophageal pressurization, about 20% of swallows. Is that 20%, right? Is that right? For
Yes.
Chicago 4? Yeah.
Yes.
And type 3, now, if my memory serves me well, I think it's just more than 20% immature contractions, right?
Plastic, yes.
Yeah. So these quite often, like, we need to distinguish that we have lots of applications that are difficult to remember, but some of them are just academic and for research use. But these subtypes here are not academic; they actually predict response to therapy, which is why it's very important to actually be able to distinguish between them. So while type 2 will generally respond to dilations or to poem, one a bit less so, and type 3 often needs longer myotomy or requires, like, it is more difficult to deal with. So what is important here, and I think you have spoken about this a lot, it's very important to know what we're doing when we're doing a manometry, so that we avoid overcalling facts and to identify how we can deal with these borderline results, that we see them more often than we think. And we can choose the right approach for our patient. So I think this is kind of the overall approach, or the overall and say about this condition without diving deeply into it. And I'd like to hand over the word to you now, Bassel, to first of all tell me whether you agree with what I've been saying so far, if you think it's nonsense. And secondly, if you would like to start showing us some of your nice slides and tell us a little bit more about this.
Yes, thank you very much for the introduction. And actually, already you did like a briefing for all the things related to achalasia, starting from the pathology and the type of the achalasia, and you just also mentioned some type of treatment and which one is the most easier, which one the most difficult. This is like a good summarizing for all these topics for achalasia. This is the third webinars related to functional motility disorder. We selected to start with the abnormal cases with achalasia, because this one, achalasia, is the most cases that referred to do high resolution manometry. Because the symptoms usually it's very clear. Usually it's very clear after we figure out that it's not cardiac, it's non-cardiac symptoms. Then, as we sure that it's not cardiac symptoms, so the first things that the physicians start to think about it's achalasia. Most of the symptoms, it started with the chest pain, or just the patient will say that I feel that the food is stuck in my esophagus, it's not coming down. So the patient try to drink water to try to push the food to go to the stomach. Or sometimes the patients, after eating some amount of food, maybe they vomit the food again because it's not passing to the stomach. So for sure, the first thing the physician should do is to do scope to make sure that there is no stricture, nothing. It's everything's in type of anatomy, it's normal and clear. And for sure, by scope, they can predict that it's achalasia. For esophagus, it will be the body of esophagus, it will be dilated, and the LS, it will be very tight. So then we have to do the manometry. I mentioned some points that's already included in the presentation. So the definition of the achalasia, as it's characterized by two main things. It's the absent peristalsis, the esophagus body, and also it's abnormal relaxation of the LES. These two things, it should be both of them should be in achalasia. We will see it now how we'll later on how it will be look like. And you also mentioned what is the cause of behind the achalasia, and for sure it's results in functional obstruction at the EG junction.
Yeah.
Now, so this is what it is. Symptoms usually, as I said, is like dysphagia. Usually, it could be solid and liquid. Sometimes it's only solid, but most of cases it will be solid and liquid. And also the regurgitation for the undigested food, and also I said chest pain. Patient who start weight loss, and they may feel heart pain. It's sometimes here we have to distinguish between the heart pain if it is related to the GERD, or it's heart pain as a symptoms for the achalasia. And by doing the manometry, we can differentiate. Sometimes some physician, once the patient came to the physician, with the heart pain, for sure they will start with the BBI, as this is the first step to be done for the GERD if the patient suspected to have GERD. So if the patient responds to the BBI treatment, that means this heart pain is because of the GERD. If there is no response, so for sure now we have to move either to do the manometry to make sure that it's not GERD, or at the same time also it will be the first step before we do the pH impedance recording to also to rule out the GERD. And also, as you said, as you mentioned before, that the patient may suffer from the nocturnal cough and or aspiration. Also, we mentioned that it could be diagnosed by barium. We will see some photos how it will look like in the barium, and again also in the by endoscopy and the high resolution manometry. It's in the standard and the definition for the achalasia as per the Chicago classification. It is two things, as I mentioned. It's elevated median IRB, integrated relaxation pressure, in both supine and upright. Now, it's not mandatory to do like both supine and upright positions. We will discuss when we will see the case. And for sure, there should be absent in the peristalsis. So this is the definition from Chicago classification. It's very simple and very clear. Again, as you mentioned, that we have three types of achalasia. We have type 1, type 2, type 3. In type 1, all of these three, we should have elevated IRB. This is a must, but it's not enough. It's a must, but it's not enough. For achalasia type 1, should be elevated IRB. It should be as the last reference number for IRB, the normal, it's around 20, 21. This is the normal IRB. So it should be above 21, 22. And for achalasia type 1, it should be with 100% filled peristalsis. It means there is no peristalsis at all and no pressurization. We will see some photo now. So no peristalsis, 100% for all the swallows, and no pressurization. For type 2, we will see some compression. It should be compression, and there should be pathophysiology pressurization in more than 20% of the swallows. Okay, and in type 3, again, it should be elevated IRB, and more than 20% should be premature contraction, or what we call it spastic contraction. It means that this latency should be below 4.5 seconds. Okay, so the most common type, it is type 2, which is good for the patients because it's the most the higher response for the treatment. It's for type 2, so it's good that type 2 is the most common. And good to know, just to think about why type 2 it is the most the higher response for the treatment, because at least in type 2 there is still pressurization at least. So that means the main problem is in the elevation in the IRB value. So if I can treat this elevation in the IRB value, that means I can help the peristaltic to be at least to back somehow to the normal. And also we have to know that usually the achalasia, it started from the tightening in the LES. So when the LES started to be tight, then the esophagus start to be dilated. So once we in type 2, once still that we have pressurization, that means still the esophagus trying to contract. But because of the LES, it's very tight, so it's not opening, then started to be dilated. So once we treated the elevation in the IRB, that means it can help the patient to restore the peristalsis in the esophagus. As per the Chicago classification, this is the criteria that we have to follow to differentiate between the achalasia, the 3 type of achalasia, and also to differentiate with the other type of functional motility disorders. First of all, we have to look for the IRB, the integrated relaxation and pressure, in the primary position, which is supine position. And we already talked about this one, that protocol, we have to give the patient 10 wet swallows. Then if it's the IRB is abnormal, then we have to look for the peristalsis, if it is normal or not normal. So it's in achalasia, it should be 100% absent peristalsis. It should be absent peristalsis. So it depends on the type of achalasia we will see. Then we will see if it is 100% filled peristalsis without pan-esophageal pressurization, BEP, that means it's achalasia type 1. But here in achalasia type 1, we have to differentiate between achalasia type 1 and absent contractility. Because if we just look for the peristalsis, if there is no peristalsis, so it may be absent contractility or achalasia 1. But the criteria here, it's the IRB. So if we have elevated IRB, that means it's achalasia type 1. But if it's normal IRB and there is 100% filled peristalsis, that it's the classification. In this case, it's absent contractility. Okay. So, and now if we have 100% filled peristalsis, but we have pan-esophageal pressurization in more than 20% of the swallow, that means it's achalasia type 2. And if we have more than 20% of the swallow with premature contraction, we will see what it means, premature contraction. It means that distal latency is below 4.5 seconds. So that means it's achalasia type 3. So this is the latest classification by classification 4. I think we will see. This is the simple comparison between the 3 types. I think it's already mentioned, but we can see.
I see only the first slide.
You mean
if you can do full screen and as start presentation, maybe.
You can see which slide now?
Now I can see the achalasia subtypes 1.
Subtype 1, 3. Okay. So
this now a little bit. So I think let's go and look at some photos here and see what it looks like in real life.
Exactly. So now this is it will see here. So now we can see this is the first one on the left. It's the type 1 achalasia. You can see that we will start, as we said, from the IRB, from the bottom. This is the IRB. It's 21. It's above 20, 21. So it's elevated. You can see in the middle there is no pressurization, no peristalsis at all. In the middle, it's achalasia type 2. We can see that, again, the IRB in the bottom, it's elevated, and there is pressurization between the UES and the LES. In type 3, we can see that it's achalasia type, that IRB is also elevated, and we can see that here we have premature contraction. Why it is premature? Because it's the distal latency here. It is 3.9. It's below 4.5. That means it's premature contraction. So this is the how it look like. But for sure, you know that we have to do 10 swallow. This is very clear that type 1, how it will look like.
Yeah.
Okay.
Very clear. Very clear.
Very clear.
Yeah.
Again, this one to differentiate between type 1 and absent contractility. In absent contractility below here, in at the bottom here in IRB, it will be normal. It will be exactly the same. No peristalsis at all, but IRB is normal. That means absent contractility. But once we have here IRB, it's abnormal. That means it's achalasia type 1. And this is when the achalasia type 2, you can see this is the pressurization. We should have pressurization from the top to the bottom, from the UES to the LES. We will see now it's real cases that we did with it's very typical achalasia type 2. And this is the type 3. Again, type 3 that we should have spastic contraction, or what we call it's premature. It means that the distal latency, it is below 4.5 second. Okay. So how here how it look like with the barium? This is type 1. You can see this is we have the bird beak here, and we have dilated also.
I can't see it now. I cannot see it, Bassel. That you're still on the. Maybe if you choose presentation mode, if you
like this,
if you choose presentation mode so that you have full screen.
Okay.
Yeah, just click that one. Yeah.
Yes. You can see now type 1.
Yeah. Yeah.
Yes. So this is actually type 1, how it look like in the pario. Okay. Here we just have to just notify important things that sometimes you do like a scope, then you do barium swallow. Sometimes you can't find in barium swallow, it's not clear that it's achalasia. So the final conclusion should be done after the manometry. Why? Because you know that barium swallow, as we did it, it's like based on time. So you know that the first minute, the second minute, after 5 minutes, how much the retention, the height of the retention. So sometimes it will be not clear or not conclusive. That we have some cases that and sometimes we are not sure if it's done correctly. So sometimes we have some cases that it's the barium storage, the report it's normal, but it's in manometry it's abnormal. This is the case type 2.
I've seen
it's
this
okay.
a couple of times. Yeah.
It's type 2. You can see here also type 2.
We're still on type 1 here.
Still, I don't know why it's like this. Now it's clear. If we just stop the.
And now it's type 2. Now it's type 2. Now it's type 2.
Okay. Yes, I will continue in this situation. Okay. So you can see type 2. So again, we have big bird beak here also here, and we have panosophageal pressurization alongside all the esophagus. And this is the type 3. You can see here the spastic esophageal spasm here at the end, and also there should be like bird beak, and sure the distal latency will be abnormal. But we have just to also to put in our mind, it's not always the contraction as strong or as high as you can see in this picture. The main thing is that we have to focus on it, that it is premature, and the TCI should be above 450. Okay.
Yeah.
So this is the quickly the 3 type of the achalasia. Again, during all the cases that I did and attended, that achalasia type 2, it's the like 95% of the achalasia that we diagnosis is type 2. So I will just now present some cases by the software, how it will look like.
Yeah.
So now I just this is just to present, just to remind that how the normal look like. Before that's to go to present the abnormal. So the normal is just a reminder that here we should have relaxation in the UES, and here we should have relaxation in the LLS, and this is the peristalsis. So this is the normal, and you can see how it's the value. For example, this this is swallow. You can see here the IRB, it's 10. That means the IRB is normal, not elevated, and we have here normal peristalsis. So this is how the normal swallow, how it look like. And now we'll see the achalasia, how it will look like. For example, this is the case, once we started the first landmark, then this is the first swallow. You can see here, again, this is the UES, there is relaxation. At its total, you can see it's very clear, it's very nice. You can see here, this is from the bottom, and this rectangle, we will measure the IRB. This is the IRB, it's 28. So it is abnormal. And just we have to remind that the IRB, it's relevant to the pressure in the stomach. So we have to make sure what is the position of the stomach sensor. You can see, for example, if it's like in this position, which is wrong position, the IRB, it will look normal, which is not logic. But should be at least 2 centimeters below the LES. So you can see now it's abnormal.
Yeah. Absolutely.
Here we can see that it's the esophageal pressurization. What it means, you can see that pressurization from the top to the bottom. And also we have here to be careful that when we will see the pressurization in diagnosing achalasia, that this value, the isobaric value, should be 30. Let's be like this. What it means 30? You can see if it is 20, you can see maybe it's like, or above, maybe the pressurization is not clear, but it should be 30 to make sure this is the cutoff for the pressurization to make sure that it's achalasia.
Yeah. Okay. Very clear, achalasia type 1. Very clear.
And as we said, that classification should be like more than 20% about esophageal. So this is the first one. I can see, just move quickly. It's all pressurization. But we can see here, for example, in the swallow number 5, there is no pressurization. Why? It's when we started, it's what there is pressurization, but then there is no pressurization. This is something that we can see. It's normal that maybe because after like maybe 3, 4, 5, it's maybe after 9 swallow, LS it's relaxed, so the pressurization it's decreased. That means all the liquid in the esophagus will go to the stomach. So it means that LS relaxed, so there is no pressurization. But what we will see that the pressurization again, it will be built up. Okay.
Right.
So we go, you can see this next one again. Now see, this is number 5, no pressurization. Again, number 6, again pressurization, again 8, 9, 10. You can see now 10 it's less. And if you continue, there is now this is resting. Maybe if you continue again, it maybe decrease, then it's increase again. So for this reason, the classification, it's based on the percentage, not only, I mean, it's 2 or 3 only, it's percentage from the total. It should be more than 20% of the swallow should be pressurized. We have also another nice case, this one. Unfortunately, it's nice case to be presented as achalasia, but for sure it's not nice for the patient to have achalasia, but this is what we found. So this is the landmark. From the beginning, we can see how much it's the LES, that's high pressure. Then to the next swallow, here it's still there is pressurization, but it's still not clear. I mean, there's no pressurization from the top to the bottom, but IRB it's also 29. Then let's move to the next. Also IRB is 36. Now we can see that started to pressurization. It's more clear now from the top to the bottom. IRB is 28, and this is the next pressurization. Next pressurization again and again. And we have some cases that by progressing with more swallow, maybe we will not be able to continue. Why? Because maybe after like 7 swallow, the patient maybe vomit, because all the water it's retained in the esophagus. Then will be not able to continue. Maybe he will vomit. But for sure, if you have this case, it will be very clear that it's achalasia. You can see, yeah, and you can see here how much now it's the pressurizing. It's become more stronger and more wider. You can see.
Yeah, it's very nice. This is
the average
textbook
clear.
stuff.
Yes, it's
And
very clear.
yeah, yeah, it's clear as day.
Yes, it's very clear. Okay, so again, just here, just to again to focus on the point about measuring the IRB to make sure that this the last. Let's make it like here. This last channel, that one should be. We have to make sure that it is in the stomach, because if it is very close to the LES, maybe it will give normal, which is wrong. Okay. So unfortunately, I don't have cases for the achalasia type 3 or type 1, because we have a lot of cases absent contractility, but not achalasia type 1 most of the cases. But the most common is achalasia type 2.
Yeah.
So this is quickly and everything we have to know about achalasia. It's not that complicated how to know, but I think I don't know if you agree with me. It's how to select the right treatment. If it is achalasia type 1 or 2 or 3. I think that's most difficult rather than to diagnosis. Diagnosis will be it could be predictable by the scope. Then it could be conclusive by the manometry. Then it will be the job of the physician or the gastroenterologist or for the surgeon to select the right treatment.
Then you can stop sharing so that you get your on the back about it.
No. Okay. So I hope everything's clear. And it's quick. It's
because I think it's as you said, it is like once you know what you should be looking at, and I think we spent a lot of time last time on breaking down really how you should deal with your machine and adjust everything before you start the reading. I think is very important, right? Because if you don't
100%.
make those adjustments, you're gonna get like either right readings or wrong readings.
Exactly.
And then you may subject the patient to something they don't need. So I think in terms of like looking at whether it's type 1 or type 2 or type 3, at the end of the day, some sort of pattern recognition for anybody who's doing this. And in terms of like, I'm pretty sure like these machines will have AI integrated in them sooner than later, that they will start reading a lot of things for you, including like the adjustment of where things should be. I mean, it's I don't think we're far away from that. So I don't think for physicians who want to deal with this stuff, they don't need to know what everything exactly looks like right away. I think it's much more important to understand these terms, IRP and DCI and the latency period and all of that. So that it becomes much easier for them than when they look at these different colors, they can actually tell them apart. And I mean, the cases that you showed for type 2, this is like just textbook cases, right? Almost.
Yes.
Yeah, but I think quite often when you do like barium for type 1 and type 3, you also get something that's pretty clear. It's usually not that subtle. Especially if the patient presents, when the patient presents to us, their symptoms have been around for a long time. So they have some anatomical changes. I don't think they just like they just appear out of the blue. So I think barium does a lot too here, you know, and everybody who suspects something like that, they should start with their scope, and they should do the barium, and then they go with the high resolution manometry. I think that would be a very nice approach to these cases. And then from there you decide the right therapy. So I think what you presented was really great because you always remind of the normal, which is very important. You need to understand what the normal looks like. And only then you can start speaking about the abnormal things and pathological things, and we're really dealing with something that is quite rare. So it's important that not everybody does this. It should be centralized centers, or like, you know, there's expertise in reading those reports and in diagnosing the right therapeutic modality for the patient.
Yes,
So I don't think it's for everybody. It's not for everybody, right? So I think this was really great, Bassel. I mean, I always learn so much because I always like the way you have built, but you're very pedagogic about how you do things. So I always learn a thing or two that I never knew about the topic. So like,
yes.
uh, I'm really happy and glad that you continue joining us on these webinars.
I just have one comment regarding the AI. I believe for sure the software will be, I think, more there is more developing on the software to find out that what should the diagnosis. But I believe that's still the last decisions for the what is the treatment. It should be by the physician. I believe that's never
Yeah,
will be by the AI, because why you
absolutely.
have to combine the for example the gastro enterologist, you have to combine to all I mean the history of the patients, what he did, the medications and the CT
Mhm.
scan and maybe the barium, many things, and he has to consider. And sometimes even for example, if we upload all of this data to the machine, I mean to the AI,
Mhm.
maybe the machine can give us the conclusion, but sometimes there is something it's between the physician and the patient himself, some discussions, maybe you can figure out some symptoms that it's even some maybe some you know that maybe there is some feeling from the physician himself about the case, what is should be the real case, then he can make
Yeah, absolutely.
his decision on the last conclusion of the treatment.
I mean, all of these things are just tools. So
Yes, exactly. Yes.
tools
This is
for the
the best
physician
best
to
description. It's tools. It's tools. Yes, it's not everything.
yeah.
It's just tools. Yes.
Yeah, so I think any pregnant individual dealing with this, and I think most of our colleagues are reasonable when it comes to this, that we understand that, and the toolbox is just getting bigger and bigger. You know, we just have more and more technology coming
Yes.
in, so it's very important to really pick and choose the correct tool for the correct diagnosis, and then based on that decide. And I think the most difficult of it all is when you decide not to do anything, because I think
Exactly.
we're always eager to do stuff, but quite often the right decision is not to do anything.
Exactly. Yes.
I
Yes.
think that's something that is quite difficult for a lot of us to doctors to actually follow. That we don't always, do what we preach. You know, we sometimes say, "I don't do anything," but then we want to do something because the patient is there and wants help, and saying that,
Yes.
doing nothing. So I think it's what you're saying is really correct and really true, and I fully agree with you there. Very
Yes.
nice, Basil. Thank you very much for today.
Thank
This
you very
was
much.
great. I think we will be discussing later the topic of the next episode. We still have, I think, we still have maybe two more to go through the whole, spectrum
Yes.
of what we need to discuss, and what we need to break up people, and uh, planning hopefully for at some point during the 2026, towards the end of 2026, we'll probably have a workshop or a symposium that is dedicated only to these functional disorders and their diagnostic methods, and hopefully by then we'll even have the endoflip on site,
Yes.
and maybe even the mucosal integrity device and that
Yes.
stuff, so
Yes.
that we can actually show different aspects of that and train people. So thank you very much for tuning in,
Thank you. Thank you very
Bassel. I
much.
really appreciate it.
Thank
And
you for your time.
I wish you, thank you, and I wish you a great evening.